You are viewing this section on the EVO phakic intraocular lens, or ICL, either because you're too nearsighted to have LASIK or PRK, or the configuration or thickness of your cornea is such that it wouldn't be safe to perform LASIK on the surface of your cornea. Please review or re-review this section on LASIK, as many of the realistic expectations as well as the side effects and some of the risks and complications are the same for LASIK as they are for the EVO phakic intraocular lens. Now, the EVO intraocular lens, also known as the EVO ICL, is a small, soft lens, similar to a contact lens, which is permanently placed inside your eye, underneath the iris or the colored part of your eye, but over the natural lens inside your eye. It cannot be seen. The procedure consists of making an ultra-small incision right where the white of the eye meets the colored part of the eye. The lens is then rolled up in a small inserter and placed painlessly underneath the colored part of your eye. This lens diminishes or eliminates both nearsightedness and astigmatism. The procedure is performed under local anesthesia at our federally certified ophthalmic ambulatory surgery center, and it takes about 15 minutes to do the procedure for each eye, and we do both eyes the same day. You're at the center for about 2 hours, where we prepare the eye for surgery and then examine the eye after surgery. Then you go and have some lunch and come back, and I carefully examine the eye about 2 hours after surgery just to make sure that the lens is in perfect position and that the pressure inside the eye is normal. Then you go home and rest and relax and start your eye drops, and I see you the next day. You can actually go to work after your first post-operative examination. Now, the realistic expectations for these procedures are quite similar to LASIK. The results are excellent, but particularly in the very nearsighted and astigmatic eye, the results are not necessarily perfect and may require a LASIK or a PRK touch-up to fine-tune the vision in about 6 weeks after the ICL surgery. There's no extra charge if a LASIK or a PRK is required to fine-tune the vision. Having said that, only about 10% of people actually require a fine-tuning touch-up after the ICL. However, we don't know who will or who won't require a touch-up, so accordingly, everyone must plan for the possibility of a touch-up. Now, if you're having the surgery because the configuration of your cornea is underlyingly abnormal, such that it's unsafe to do a LASIK, then a touch-up after the ICL may not be possible due to the irregularity of the cornea. And in those cases, although your vision will be enormously improved from before the ICL, to fine-tune your vision, glasses or contact lenses would be necessary because it wouldn't be safe to perform a LASIK or a PRK. Now let's take a few minutes to explore the potential side effects as well as the risks and complications of the EVO ICL surgery. Again, please go back and re-review the LASIK video because many of the realistic expectations, the limitations, and the risks and complications are the same for LASIK as they are for the ICL. For example, the possibility of overcorrection or undercorrection of the nearsightedness or the astigmatism, or the induction of astigmatism where no astigmatism existed before is essentially the same for LASIK as the ICL. Additionally, the possibility of glare and halos or starburst or decreased contrast appreciation and possibly poor night driving vision is rare but possible. The potential need for glasses after the surgery, particularly for night driving, is about the same for ICL as it is for LASIK. It's not common, but it's possible. Of course, if you're over 45 and we do not adjust one eye for near and one eye for far, which is called monovision, then reading glasses will be necessary. Now, what about the actual risks and complications? Well, the good news is that they're super rare, and like LASIK, they can be categorized as mild or severe. Now, they're slightly different than LASIK in that LASIK is surgery on the surface of the eye, that is outside the eye, whereas the phakic intraocular lens involves actually going inside the eye, which carries its own set of unique risks. The mild complications consist of chronic low-grade inflammation inside the eye or possibly low-grade increased pressure inside the eye. These conditions can be treated with drops, but very rarely they may require the removal of the lens and the need for continuation of drops for many years. Fortunately, these complications are very rare, and actually in the FDA trials, as well as in my own personal experience, these complications were never experienced. Extremely rarely, the implant must be removed and replaced with a different implant, either because the size or the power is not exactly correct. Rarely, the implant must be removed and not replaced because for some reason it's not working for the patient. Fortunately, unlike any other refractive procedure such as LASIK or PRK or SMILE, the lens actually can be removed. This, of course, requires a second procedure, but the good news is that it's possible to remove the lens if necessary. Now, what about the serious complications? Again, these are extremely rare. In fact, if they were common, the FDA would never have approved these lenses in the first place. They consist of the possibility of a serious infection inside the eye. Now, if that happens, and it's mild, it can simply be treated with drops and possibly the removal of the lens. But if it's very severe, it can result in total blindness of the eye or even loss of the eye completely. This was not seen in any of the multiple FDA trials and certainly has never occurred in any of my patients. The pressure in the eye can go up to very high levels, usually in the early postoperative period. In these cases, we can adjust the pressure with certain maneuvers, or rarely the lens must be removed. This can result in a slightly larger pupil or an irregularly shaped pupil. Now, bleeding is also a possibility, requiring the procedure to rinse the blood from the inside of the eye and possibly again to remove the ICL. However, this was not reported in the FDA studies and has never happened in any of my cases. Additionally, there can be problems with the optic nerve or the blood vessels in the back of the eye, or problems with bleeding underneath the retina in the extremely nearsighted person, or even the possibility of a retinal detachment, again, occurring in the highly nearsighted individual. You have to understand that patients undergoing the ICL procedure, for the most part, are very, very highly nearsighted. And those individuals run an increased risk of retinal detachment or bleeding underneath the central part of the retina, even if no surgery is done. So it's not clear whether in the FDA studies, the very few patients that experienced a retinal detachment or bleeding under the retina would have had that even if they never had surgery on the eye. Again, in my experience, I've never had one case of an infection, a retinal detachment, bleeding inside the eye, or bleeding underneath the retina. Now, in the original ICL FDA study, about 1.5% of patients developed a cataract inside the eye as a result of the ICL. However, in the EVO FDA studies, no patients developed a cataract. However, realistically speaking, with experienced ICL surgeons across the world, about 1% of patients do develop a cataract inside the eye directly as a result of the ICL. This can be easily treated by removing the ICL, then removing the cataract and placing a new implant inside the eye, such that the vision without glasses or contacts is restored to the excellent vision achieved with the ICL. The only downside to this is, of course, it requires a second surgery, and the cataract surgery itself has potential risks and complications such as bleeding, infection, and retinal detachment. The good news is that in my experience, only about 1% of people required this second surgery, and the results have been excellent. I understand that these complications seem frightening, but like LASIK, we have to keep them in perspective, and when complications do occur, they tend to be mild. ICLs are safe and effective. I have implanted more than 25,000 of a similar lens in association with cataract surgery, and my complication rate is exceedingly low. My infection rate is about 1 in 4,000 cases, and in those few eyes that have developed infection following cataract surgery, not ICL surgery, with treatment, excellent vision was achieved and certainly never resulted in the loss of an eye or anything serious like that. We implant EVO ICLs with my very experienced and dedicated surgical implant team in my own federally certified ophthalmology ambulatory surgery center. Serious complications can and do occur, but I'm happy to say that they're generally mild, and in my experience with the EVO ICL, I've had no significant complications, either infection or bleeding or retinal detachment, and certainly no serious complications resulting in loss of vision or the loss of the eye.